I'd like to welcome Dr. Sasha Blaskovich to today's session.
Thanks for having me, Athena.
Today, we're going to discuss non-invasive techniques for management of persistent misalignment. That's a mouthful. For realignment of the atlas with the goal of restoring proper alignment, alleviating nerve pressure, reducing interference in the nervous system, of course, improving CSF flow, and promoting overall spinal health. As usual, we'll cover the merits of each method and share some of the risks in each. So let's start, Dr. B, with introducing some of the contraindications of patients who should not receive chiropractic care, where more harm than good can result from spinal manipulation. I'll introduce some of them: spinal cancer patients, osteoporosis patients, spinal deformities, and if you'd like to expand upon this.
Yeah, definitely. I think first off, there is no one chiropractic technique, and so truly in an idealistic world, there is no real contraindication to chiropractic care for anything. Where the kicker comes is that the chiropractor's job is to properly evaluate and diagnose and come to a concrete, knowledge of the patient that they're dealing with, and then pick and choose the most appropriate technique that will be minimally invasive for that individual in their situation. But when it comes to, contraindications for what I guess the mainstream and people believe is chiropractic, which is sort of really the stuff you see on Instagram with, you're listening for those loud pops and they're doing those quite, strong and forceful maneuvers. When you have those demographics, like you're saying, someone with bone cancer, someone with osteoporosis, someone who's elderly and maybe doesn't have osteoporosis, but has osteopenia, which is borderline osteoporosis, you have to be cautious. They're at risk no matter what, even whether or not at the chiropractor's office. But when you have spinal instability, that's in my humble opinion, in my experience, that's a huge no-no for doing the more forceful maneuvers, especially to the upper cervical spine and what we call the occiput. Because there is a risk there of aggravating things quite a bit, and thankfully, 99.9999% of the time they all settle down and nobody's worse for wear. But it shouldn't be being done if if the chiropractor is aware that the patient has spinal instability. It should be very cautious techniques used for that.
And I would say that one of the difficulties for the practitioner and the chiropractor is identifying those cases prior to the imaging, because they do exist where they're in an in-between stage developing more severe problems, but yet not yet identified as such.
Correct. Yeah, the history workup, so detailed questioning, the request of past imaging, current imaging, and comparing, progress or lack of progress of a particular thing that was noted on past imaging. Those are all crucial factors in determining how to best handle a case. It's really hard to divine just by palpating and feeling somebody, exactly what you're dealing with. I mean, it's relatively, the confidence level is relatively high, but when you can add imaging to that and very detailed questioning, because a lot of the times patients don't divulge stuff unless we probe and push and sort of prompt them to think about things that they don't think about naturally. It'll give us a much better standpoint to work with and deal with them, so that the risks are, next to zero, I guess.
Yeah, as minimal as possible. So no popping, twisting, or cracking.
When you have, for the upper cervical spine in particular, because that's,
yes,
I mean,
for
I
the
can
upper
speak
cervical spine, yes.
Yeah, I can speak to that the most, fervently, because that's what I deal with the most and have seen. And it's not just chiropractic; it's any manual modality, whether it's physiotherapy, even massage, osteopathy, and exercise therapy, kinesiology. They all have the propensity to work on mobilizing joints and increasing joint mobility. And when your upper cervical spine has excessive joint mobility, that tends to aggravate the situation when the focus of the therapies is rigged at increasing joint mobility to that specific region.
I think great caution is it's an opportunity for us to talk about this, because there are a number of injured patients after some of these effects, whether through one practitioner or another, as you allude to, that aren't properly proficient in this area. So you need a lot of expertise to handle these problems. So let's turn now to upper cervical chiropractic. Can you introduce what distinguishes an upper cervical chiropractor from a traditional chiropractor, and also what they share in their fundamental knowledge and training?
Well, in general, an upper cervical chiropractor, their clinical focus is on assessing primarily what's happening at the atlas. So how the atlas interrelates with the skull and interrelates with C2. And that'll predicate a lot of um, symptomatology that a patient can have body wide. I mean, they could even be presenting with numbness and tingling in their feet, and it somehow stems back to the atlas. And when you understand what the atlas protects with inside of its canal, being the last part of the brainstem and first part of the spinal cord, you can imagine the vast array of body wide connections that this can pose a risk to, as far as a person having symptoms, where upper cervical chiropractic, who focuses on the positioning of the atlas, can provide dramatic benefits to these patients. Um, the the premise is that their focus on the atlas is dictated by a much broader study of that region and how to assess that region after they've already graduated from chiropractic. So you could almost consider an upper cervical chiropractor a chiropractor who's finished chiropractic and then has taken a diplomate level course system to become a specialist, if you will, just like a medical doctor finishing their medical residency and then going to become a neurologist or a pediatrician or a gynecologist or something specialized. And in this case, it's the chiropractor becoming very specialized in assessing, the upper cervical spine, and most particularly the atlas. And then based off of their evaluation of the atlas, then, directing a corrective maneuver with a three-dimensional vector system to position the atlas back to where it would be the proper positioning as it relates to the skull and C2, thereby reducing the neurological interference, or suspected neurological interference on the cervical medullary region, which is where the cervical spinal cord and the medulla oblongata connect, and thereby reducing severe dysfunction and severe impairments on patients on a regular basis. And part of their protocol is doing very specialized x-rays of the upper cervical spine in 3 dimensions, where they can triangulate the proper adjustive vector, and a vector is basically a direction of force, so that they can make a 3 dimensional correction to the atlas, thereby restoring proper nerve flow and body function and homeostasis.
We'll talk about those in a minute. I'll introduce them, but I want to say, to your point, that the effect of the correction on the atlas influences the spine. And this isn't widely known, that the rest of the spine contorts and adjusts for the misalignment.
Correct.
Let's turn now to Atlas orthogonal technique, often referred to as AO. Atlas orthogonal technique is performed by specialized upper cervical chiropractors, as you've indicated, using a percussion instrument and an accurate measurement from cervical x-rays to program the corrective vectors into the instrument. The location, can you talk about the location of the contact point just at the tip of the ear at the atlas vertebrae? Can you
Correct. Yeah,
demonstrate that?
Yeah, go ahead. Sorry.
And also introduce how cervical x-rays are used by the AO chiropractor and speak to the x-rays?
Sure. Now, I'm personally not an AO chiropractor, so I might butcher this a little bit. This is going to be more of what I've seen colleagues do. And they have very specialized equipment that sort of, positions a person and then basically holds them in place with special gadgetry, so that there's no movement on the patient's part, so that the chiropractor is dictating their position. And like I said, they take an X, Y, and Z, or Z if you're in the States, vector x-ray, so they can basically take each one of those single dimensions and have a 3 dimensional concept of how they're going to set up their stylus to do the adjustment, so that they 3 dimensionally correct what they see there. And the atlas orthogonal is one of several upper cervical techniques, and I believe things kind of started with the Grostic era, that was using your hands to correct the atlas, and then that transformed into Nucca, and then Nucca into atlas orthogonal, and then after atlas orthogonal we have advanced orthogonal. So they're all variations of the same thing, but just dictated by how the corrective procedure is performed. But what they have as a similarity is those 3 dimensional x-rays to determine the proper vectoring or direction of adjustment that they're going to do to make a proper corrective maneuver to the atlas.
And the procedure itself is quick and painless, although I want to say that the post-adjustment outcomes And the system may require some time to adjust to the new setup, so to speak. So I found that sometimes you can be down for a day or two as your body readjusts to the realignment.
Correct. Yeah. Yeah. There's always a possibility for a refractory period. I mean, when you're looking at the central nervous system, so brain, brainstem, spinal cord, the recalibration of those central nervous system and anatomic structures is slower than the recalibration of, for example, a peripheral nerve. So if you hit your funny bone and you got the tingling in your pinky, that recalibrates when you take the pressure off of it. In a simplistic way of putting it, when you take the pressure off of a peripheral nerve, it recalibrates itself quite a bit quicker than a brainstem or a spinal cord. And so you can absolutely have a longer refractive period before that recalibration has assumed its full potential.
Exactly. This takes some time to adjust. I want to speak as well about the measurement of the vectors, which we talked about, and the accuracy using the X-ray for purposes of obtaining the proper measurements and vectors. I'm told that the accuracy rate is high, and you can correct me if I'm wrong, approximately 80%. But I want to say, and I have very personal experience with this, that what's not visible are cases of anomalies in the bone, where off something might be visible in an upright MRI scenario. So this can, as a consequence, result in incorrect vectors, which I've actually experienced for 4 months, and potential pooling of CSF. Let's speak about, you also mentioned that DMX may come in, but not necessarily for purposes of the measurement of the vectors, but DMX may come in later for patients. Can you talk about where this might come around in the process for certain patients?
Right. So not all patients, thankfully, have upper cervical instability. A vast majority of them have simply a positional anomaly that needs to be corrected with this three-dimensional vector system. And so where DMX comes in handy with this sort of demographic of patient is when a patient repeatedly has a problem holding their adjustment or holding the proper positioning of what was deemed the malposition with the three-dimensional X-ray. And thereby the suspicion gets elevated that potentially the reason they're not holding their correction is because their ligamentous integrity has been compromised either by injury or some inflammatory condition or some connective tissue genetic disorder, whereby the proper tensile length of the ligaments that properly hold the atlas and axis and the atlas to the skull together have been lengthened, thereby creating too much movement in those bone interrelations, resulting in the inability, I guess you could say, to properly hold a correction. And at the end of the day, that should prompt sort of the suspicion, hey, do we have an unstable upper cervical spine here, whereby it's not holding its corrections as we're used to seeing in the vast majority of our patients. Thereby, the only way to properly assess in real time whether you are dealing with an excessively mobile upper cervical spine, instability or hypermobility, would be to do a motion X-ray to determine that.
Next, let's introduce the Nucca technique. Would it be fair to say that the Nucca process works to reduce the interference to the nervous system and all the benefits in the same manner, similar to Atlas Orthogonal? And I just want you to share your opinion as to both methods, if you find, based on your years of extended experience and your collaboration with other chiropractors in provinces, if you find one is preferential to the other.
Yeah, so like I said, I'm not an upper cervical sort of Nucca, AO, Advo, or Grostic type of practitioner, but I do have a lot of connections that do perform that specific variety of techniques. Um, Whether I've seen a dramatic benefit over one technique over the other, I think I have not. I think they're all very beneficial for the type of problem that they address when it comes to the three-dimensional positioning of the atlas. Nucca uses the hand. AO at Atlas Orthogonal uses an instrument. Advanced Orthogonal uses an instrument. Grostic uses the hands. And again, I think the proficiency and the experience and um, the prowess of the doctor is probably more crucial than the technique itself. And so, but yet I have not met a single upper cervical chiropractor, whether it would be, Grostic, Nucca, Atlas Orthogonal, Advanced Orthogonal, who wasn't a mad scientist that really had a passion for what they're doing. Because I think the level of additional education that requires after you're done chiropractic, and you could literally just go to town and be a chiropractor, takes um, a lot of dedication and sort of this, outlier sort of concept of wanting more out of what you already have as far as knowledge and capacity. And so I find that all the upper cervical chiropractors that I've ever interacted with are extremely scientific, extremely proficient, extremely dedicated, and extremely specific in what they do. So I would call them nerds, kind of like I'm a nerd with when it comes to motion x-ray and the technique that I use for the upper cervical spine, because I want to know exactly why it works and what the deepest core of the neuromuscular physiology is and why it's having the effect that it is. And so I've not had an experience where I would say, one of those particular techniques is better than the other, because it's truly dictated by the doctor. And all these doctors that I've met, like I said, in the upper cervical spine world, they're science nerds, and they're all very good at what they do.
Yeah, I would agree. I think the passion, the commitment to their patients, and the tenacity, they show up every day, every week, trying to better the health and well-being of the patient. So I agree with you, and also trying to find new and inventive ways to manage a significant problem that's life-altering.